Good afternoon, everybody. My name is Vaughn Edelson. I'm Programs Manager at Genetic Alliance. Welcome to today's webinar, The Value of Family History in the Prenatal Care Setting. Today we have with us Dr. Siobhan Dolan. She's an obstetrician and geneticist with an interest in public health. She is currently an associate professor in the Department of Obstetrics and Gynecology and Women's Health at the Albert Einstein College of Medicine, Montefiore Medical Center in New York City. She also serves as a consultant to March of Dimes. Today she'll be presenting a Grand Rounds webinar on how family health history is applied in the prenatal care setting. So welcome, Siobhan. Just a few quick reminders for our participants before we get started. All participants are on mute during the call. If you have questions for the presenter, technical questions for us, or any comments, please submit them via the question function on the webinar panel, which should be on the right hand of your screen at any time during the call. The last about 15 minutes will be dedicated to questions and answers, so you can submit the questions throughout, and we will moderate that Q&A at the end. And this session is being recorded. It will be available for streaming and downloading next week. And finally, we ask that you please fill out the automated survey after you exit the webinar. We appreciate your feedback. With that, I will turn it over to Siobhan.
Thank you very much, Vaughn. Good afternoon. I'm delighted to be here today, and I'd like to thank the Genetic Alliance for inviting me. What we're going to talk about today is the value of family history in the prenatal care setting. And I'll start by giving you the context for this presentation. With HRSA sponsorship, we have had the great privilege at March of Dimes of working with Harvard partners, NIDPEG, and Genetic Alliance on a project to develop an electronic point-of-care tool to collect family history and use it effectively in the prenatal care setting. So we've had a fabulous collaboration, and in addition, we've had the wonderful work of Holly Tutko, a student and professional who was part of her program was working with Sarah Lawrence College and developed the slide set. So I'd really like to start out by saying this is a tremendous collaborative effort, and specific thanks to Holly for developing this slide that I'm privileged to present today. What we're going to talk about is the value of family history. We're going to talk about some family history collection tools that will help us identify red flags for genetic conditions. And then we'll think a little bit about risk assessment and management guidelines. And this is really going to be an ongoing issue, how to get management guidelines to the point of care so patients and providers can use family history effectively to guide their health. And then I'm going to illustrate some of these issues through case studies in the prenatal setting. Again, this is a terrific collaborative work of many partners, including HRSA, NIDPEG, Genetic Alliance, Harvard Partners, and March of Dimes. So thanks to everyone. Also, I'd like to conclude at about 15 minutes before 1 o'clock, so we have time for Q&A which can be done as Vaughn pointed out, and I'm delighted to answer questions. So we'll start with a family history. Any of you practicing in clinical genetics will recognize this kind of pedigree, and for those of you for whom it's new, we have a 3-generation pedigree. We have usually what we call the proband, the person sitting in front of us right here with an arrow pointing to the person, and then we have their first generation, their parental generation, and then their grandparental generation. This is a pictorial representation of a family. The lines show how folks are related to each other. Circles are indicating women, squares are indicating men or boys, and then we usually start to add in some additional information about family history, medical history specifically. You can collect other kinds of family history, which can be extremely useful and often a good adjunct to the medical history, but we'll talk today about medical or health family history. So why would we do this? What would be the value of family history? And it has actually many values. First of all, to inform diagnosis. So if we start to hear about a family history of many folks with the same cancer, or a cancer that seems to have a clustering around perhaps a unifying genetic diagnosis, this could help us start to think about, is there something that this particular patient is at risk for? It also can then help us further think about risk assessment. So say we hear about a family with a strong history of cancer as an example, so we start to think about what kind of risk the patient is at, and then what we can do to help this individual. So are there modifiable risk factors? Can we get this individual involved in smoking cessation, as an example, to bring down their risk? And then a fourth component is building rapport with patients, and this is both through the experience of asking questions and getting answers, but also through the experience of getting to know an individual, not just as the person in front of you, but as part of a bigger picture context, in the context of their family. So how can we go about gathering a family history? And we're really privileged to be working in a setting with a lot of amazing organizations interested in family history. And here's one called Know Your Family Health History that American Society of Human Genetics and Genetic Alliance have provided leadership and put forward. And what it, you can see here the URL at the top. So it's www.talkhealthhistory.org. And as you go through some of these screens here, that you can learn about family health history, and then you can actually go into some of the tools like familyhistory.hhs.gov, which is the U.S. Surgeon General's Family History Initiative. You can actually come to the tool where you can go ahead and enter your own family health history. As I said, as part of a collaborative project that we're working on at Marcia Dines with Genetic Alliance and Harvard Partners and NICHPEG, we're creating a point-of-care tablet-based PC tool that patients will enter their own family history information, and then providers will use that information. So many of us are working in this space of how to collect this information because it's such incredibly valuable information. We want to be able to use it to inform patients' risk and then to inform improvements in their health care through risk reduction. Now, once the family history is collected, what do we do with it? And this is a real challenge for a bunch of clinicians who say, well, you told me you're, Cajun. What am I supposed to do again with that? What is it that you're at risk for if you told me your ancestry is of a certain region? So we want to also use the family history tool to help clinicians build up their decision support. And so part of a family history tool is to generate red flags and risk assessments and give the provider information about, okay, this patient told us that she's Ashkenazi Jewish. Here are some of the conditions we might want to offer her carrier screening for. And we can use, expert consultants or a panel to kind of keep that decision support up to date so that as genetics evolves and as there are more and more information available, providers can learn through using these decision support tools built into family history tools. So we want to provide this decision support. We also want to be sure that there are culturally sensitive messages being given. Some cases of racial and ethnic screening for understanding an individual's risk for being a carrier of a genetic condition based on, is this a condition that historically has been seen in some groups? Well, you need to ask that information in a very culturally sensitive way and then respond to it in a culturally sensitive way. So we want to use this opportunity to promote those messages as well. This is a wonderful opportunity to give patients educational materials. When they're found to be at risk, we want to make sure that the assessment of risk gives them a sense of empowerment. Okay, I'm at risk and this is what I'm going to do with it. I'm going to change my lifestyle. I'm going to get carrier screening. I'm going to, take a step to improve my health. We don't want this to promote fatalism. Well, oh my gosh, I have this genetic condition and I'm at risk and there's nothing I can do. So I think education is a huge component of making sure that this information is empowering. And then we also are working hard to have this information from our tool in particular compatible. So what are red flags for genetic disease? One is family history of a known or suspected genetic condition. So an example in there would be, when I hear about a lot clinically is Duchenne muscular dystrophy, where there was an uncle or a family member affected, and so an individual comes, reports this, and now we want to say, is there something going on in this family? Is this particular woman sitting in front of me who's either considering or has become pregnant at risk? Some are more subtle, multiple affected family members with the same or related disorders. And this is where familial cancer syndromes are gaining interest. Breast and ovarian cancer can cluster around families that are carrying a BRCA1 or 2 mutation. Lynch syndrome, or what was formerly called hereditary non-polyposis colorectal cancer, which would be colorectal cancer, some endometrial cancers, and so forth. Is there a clustering in a family that makes us think about offering genetic testing? Other red flags include earlier age at onset of disease than expected. And this would be a situation like we very sadly see clinically, young women perhaps in their 30s with a breast cancer. Cancer in general can be a disease that has an increasing incidence with age, and so when you see cancers at very young age, you may start to think genetic. Intellectual disability can be associated with some genetic conditions, and we will talk about that in a few minutes in one of our case studies. Diagnosis in the less often affected sex is another example. Is this something that could have a genetic contribution? So an example would be an individual or a family where there's a case of breast cancer in a male. We wouldn't expect to see that, but when we see it, we just want to ask the question, is this clustering in the family, and could other family members be at risk? And next red flag is a multifocal or bilateral occurrence in paired organs. So this would be a situation where you had, let's say, an ovarian cancer, and then a second ovarian cancer in the other ovary, or similarly breast cancer, and then a second primary breast cancer. Sometimes it's a little hard to tell if the second cancer is a new primary or a recurrence. So this is not always clear-cut. And sometimes part of the initial genetic evaluation is doing that detective work to distinguish, is it a new primary? And again, what is the familial pattern here, and does this fit together? So none of these red flags stand entirely alone, but if you start to see several of them in a family history, they can guide your assessment of the family history overall. We have a few more. Red flags for possibly considering, is this genetic? One or more major malformations. So if you see a child with a couple things going on, you might start to think, is there a unifying genetic contribution here? A disease that is onset in the absence of risk factors or after preventive measures. So in other words, let's say you've had a prophylactic oophorectomy, say you've had your ovaries removed to prevent ovarian cancer, or to decrease your risk, I should say. And it is a very effective mechanism for that. But if you do that, but then go ahead and have either a peritoneal or an ovarian cancer, then you have to ask yourself again, is this something to consider? There's something genetic contributing here. Growth abnormalities, again, can be associated with genetic contribution, as can recurrent pregnancy losses. Another thing to think about that you might see in a family history is consanguinity. So where two partners having a child are related ancestrally. And again, that used to be thought to be an incredibly high-risk situation. And the fact is, statistically, it's not incredibly high risk. It does have probably a doubling over baseline, so that's increased, but on an absolute terms, it's not a dramatically high number. And so generally with families, when we see families with consanguinity, we end up largely reassuring them, because there's often a strong sense that the pregnancy is extremely high risk. A lot of the situation there is working with a family where they are and then thinking about how to work with them to understand their risk accurately. Sometimes that means informing them of a risk they didn't know about, and sometimes it means helping families realize that there's risk, but it's not an absolute certainty that there's going to be a problem. And then the last red flag is ethnic predisposition, and I started to allude to that. There's ethnic groups in which we know there's carrier frequencies of some genetic conditions that are above others, and so we would, based on ethnic background, be thinking about offering carrier screening. And I'm going to get into that in some of the case studies as well. So here's some illustrations of conditions that we would think about based on the red flags that I've just talked about. Cystic fibrosis, carrier screening is now available and offered to women, couples of European or Ashkenazi Jewish background. Actually, in a very recent ACOG committee opinion, it was suggested that cystic fibrosis could be offered prenatally to all women of any background. And this starts to this solution is often the solution in the context of a situation where a lot of women and couples are reporting mixed ethnic and racial backgrounds, so that we don't have people falling in neatly into a box or another in terms of their backgrounds. And therefore, with cystic fibrosis, since we know a lot about a lot of different mutations, it seems reasonable to offer it to every woman who's interested. The second box on the left, on the bottom, is the panel of conditions for which we would offer carrier screening to individuals of Ashkenazi Jewish background. And that list is a moving target. Many laboratories are offering many more conditions, 19 conditions in some labs I most recently heard. And so this is going to be interesting to see. The more we learn about genetics, the more that we can offer. And is more always better, and we'll have to continue to keep our eye on that question as we see more and more becoming available. Sickle cell disease is a condition we see in the African, Asian, Indian, Middle Eastern, and Mediterranean populations. So again, in my setting in the Bronx, we offer sickle cell, we offer screening not through mutation testing, but through a CBC and hemoglobin electrophoresis routinely to every patient, because for many of our patients we have mixed racial and ethnic backgrounds, and we don't want to have someone slip through the cracks. So that's a situation where race and ethnicity may be a useful screening tool in your family history, but it may not identify everyone, and you may choose in your community where you work to offer screening to everybody. Alpha thalassemia is another hemoglobinopathy, again common in Southeast Asian, African, and Caribbean individuals. TAFAX is also offered to folks of French, Canadian, Cajun, and Pennsylvania Dutch background. So that was what I was alluding to before. And then beta thalassemia, another hemoglobin condition as well. So here's just some examples of kinds of screening that red flags you learn about on a family history screening tool that would make you consider some of these conditions for which genetic tests are available. Now, how do we go ahead with the risk assessment and management guidelines? Because we didn't, in the context of our current project, we were not wanting to recreate or initiate new guidelines. What we want to do is help bring standards and guidelines that professional societies and folks who make guidelines have already put together through work groups and think tanks and their processes. We want to bring that to the point of care. So we really use the American College of Obstetricians and Gynecologists guidelines as a primary leading force in our thinking, because of the fact that it really represents the practice guidelines that are most relevant to the prenatal care providers, the physician side. And we did consult American College of Nurse and Midwifery guidelines, American College of Medical Genetics guidelines, and American Academy of Family Practice guidelines. So we tried to be inclusive, and in most cases there was very little conflict about what was recommended. And this idea is to bring current evidence-based, guideline-based practice to family history in the prenatal setting to make sure it's informing prenatal care as well as it can. I'm sorry, here's the other sites we used, American College of Medical Genetics. Any questions? I think they could be IM'd into the conference organizer, and if you wanted to interrupt me with one, I'd be happy to try to take one as we went along, but I'll continue to go ahead with a case study, the first case study, and it'll give us some time to think about and apply some of the principles that I've just laid out.
Siobhan, we did have one question come in, so since
yes, that was great.
I will ask it. So the question is about the timing of pregnancy loss. The person says previously, I think we had used greater than or equal to 3 early pregnancy losses, but you suggest 2, so they're wondering about the rationale and the current state of the science on those red flags for pregnancy loss.
Oh, okay. That's a good question. I know I've looked it up, and I'm pretty sure it was 2. I'm pretty sure that's by American College of Obstetricians and Gynecologists. In other words, 2 or more. So certainly 3 qualifies. So in general, 1 pregnancy loss does not dramatically increase one's risk of having an underlying genetic condition, because unfortunately pregnancy loss is very common. More common than we would hope for women, but then again, it's probably, if we look at the genetic contribution to first trimester pregnancy loss is tremendous. It's maybe 50% of first trimester losses are going to have some genetic condition or abnormality, but it's not the type of genetic conditions where we would see a high recurrence risk. They're more the sort of chance sporadic events that might happen. So when we start to see 2 losses, 2, 3, or more, that's when we start to say, is there something here that's more than just a chance event, and actually we could identify. The most common thing that would be identified on a screening, an assessment of a woman who reported or presented with 2 losses would be to offer her testing for balanced translocation. So to do a karyotype where you look and see, does this individual have 23 pairs of chromosomes, and in fact, are there 2 that are stuck together so that each time an egg is created or a sperm is created, you get an unbalanced chromosomal complement, but this person in front of me is healthy. So we'd be looking for a balanced translocation. And nowadays, if you went into more, even a higher number of pregnancy losses and you had no identified cause, you could start to think about doing some more detailed genetic testing like a microarray, but that's not at all standard of care, so that's somewhat experimental for the moment. If anybody, for whomever asked the question, if you wanted any further follow-up, feel free to email me, because I'd be happy to, try to further clarify the situation if I could. But that's my understanding of the situation for the moment, and what would be looking for in 2 or more pregnancy losses. Okay, any other questions, Vaughn?
Nope, that was the only one for now.
Okay, great. So we'll start back with the case studies then, and we'll try to revisit some of the points, as I mentioned, that have come up in the family history. So case study 1 is a woman named Anna. She's a healthy 30-year-old who presents to your office for her first prenatal care visit. She's 10 weeks pregnant. In inquiring about her family health history, she reveals that her brother Harold possesses an intellectual disability. And this is an incredibly common scenario because a lot of families will report they have a family member with an intellectual disability, or another example would be autism, developmental delay, special needs, trouble in school, a variety of, sort of symptom or constellation of symptoms in intellectual disability. And for folks who are in the 30 to 40-year-old range, for an example, they may never have received a diagnosis as a child. And at this time, there may be genetic testing that's available, but people often don't reopen that question of genetic testing in an adult. Sometimes what happens then is when a woman comes to prenatal care, it requires her to open that question for herself and then sometimes for their other family members. So this is not an uncommon scenario because of the fact that genetic testing has changed so dramatically in 30 years. So if we start to create a pedigree for Anna, we put her there and it's a circle. She's 30 years old. She's pregnant at 10 weeks, so we use a diamond to indicate her pregnancy. And then we see that she has a brother with an intellectual disability. So what are we thinking? Well, if we start to think about known causes of intellectual disability, the first point to make is that most of the time we'll never exactly know. And I say that as of today, but this is an area where genetic discovery is moving very rapidly. So I certainly hope and expect that in 5 years and 10 years we'll know more and more. But today the most common reasons for intellectual disability when we make a diagnosis are number 1, Down syndrome, so that's trisomy 21. Again, not usually because of the constellation of physical findings, and because testing has been available for Down syndrome for many years. My guess is that if that was the condition, it probably would have been diagnosed, but you never know for certain. The next most common would be Fragile X syndrome, and that's actually what we're kind of talking about here. So I'll leave that one on hold as we're going to come back to it in more detail. And then the third is fetal alcohol syndrome. Incredibly important to keep in mind because it's extremely preventable and a very common etiology for intellectual disability. So places where we can intervene to help women think about cutting down or stopping drinking alcohol during pregnancy are really still very important. Other less common, but just to keep in mind, causes of intellectual disability include infections, birth defects, injuries, untreated metabolic disorders, and other genetic conditions. So there's sort of common and less common, and I kind of think of them in those 2 buckets. But if you get into less common etiologies, those would probably require a more extensive evaluation by an internist and or clinical geneticist. And as I said, that can sometimes be the case. An individual's pregnancy brings to the family new consideration of an undiagnosed individual in the family if that information is useful to planning for the next generation. So what red flags would you expect to see in the Fragile X? In the family. So for Down syndrome, it's sporadic. Typically, there's no family history, and the major risk factor is advanced maternal age. So if it turned out that Anna and Harold, say Anna was 30 and her brother was somewhat younger and had been born to a mother who was somewhat older, perhaps that could explain the fact of him having Down syndrome, although, again, more pregnancies or more children with Down syndrome are born to younger women just because younger women have more children. So the point being, Down syndrome would be diagnosed in this individual by a good physical exam and then karyotype if needed. In Fragile X, what we would see, and this is where family history can be quite useful, we see multiple family members with intellectual disability. Because it's an X-linked inheritance pattern, we see more of the intellectual disability in men. We used to say it was exclusively in men, right, because men only have one X. So if they have a mutation in their X, we're going to see the presentation, whereas women have two X's. So because some of their X's are working and some are not, we're going to see a less severe presentation of intellectual disability. And that's kind of what we see. So we have taken it away from an absolute, only men are affected, to women can be affected with a much milder phenotype. Now, because Fragile X is a triplet repeat condition, so that we see pre-mutation carriers and then full mutation carriers, we see carriers having another phenotype. Female carriers can have primary ovarian insufficiency, so that's lack of ovarian function, usually with lack of ovulation and ceasing menses by about age 40. And we can see with male carriers an adult onset tremor ataxia syndrome, which may be undiagnosed, but then when a family actually starts to look and say, is the Fragile X going on in this family, a male carrier will be identified through having these kind of neurologic symptoms. So we'll expand the pedigree in a second to illustrate some of these facets. And then fetal alcohol syndrome would be most likely identified through a good family and social history exploring the mother's potential alcohol use. So in talking to Anna further, you discovered that her brother Harold, who's 26, they have a third sibling, a sister named Marguerite, who's 22. Anna's mother, in fact, had all three children by the age of 26, so she was quite young at that time. But then she went ahead and stopped having her period at age 32, which is younger than age 40 and would be considered primary ovarian insufficiency. And in fact, the mom does not consume alcohol. So in terms of assessing all our risk factors here, or our red flags, it's starting to look more like Fragile X as opposed to Down syndrome or fetal alcohol syndrome. So we'll put all of this information back on the pedigree, and now we start to put all of these pieces together and think about red flags. So I'll just briefly review a little bit more about Fragile X. It's the most common inherited cause of intellectual disability. As I mentioned, it's due to a repeat expansion in the FMR1 gene. It's recessive and X-linked, although there is a phenotype in females. There's no cure, but therapy in the form of early intervention and can be extremely helpful and enhance functioning. The intellectual disability can be varied, so it's not, the prediction in terms of intellectual achievement can vary, and that's an important point to stress to families. It can be behavioral issues, speech and language problems. The typical phenotype is a long face, so kind of like classically I'd say the third individual from the left sort of illustrates the gentleman with glasses and the cap of that sort of long face. And boys are more severely affected than girls, as I pointed out. So now that is the situation for an individual with Fragile X, but there's a premutation carrier status, individuals who have a premutation, and they are seen in many cases for the women to have primary ovarian insufficiency. Usually cognitive functioning is normal, but those women can go on to have a Fragile X, ataxia, or tremor. Men typically, who are premutation carriers, typically have normal cognitive function but can have that late onset Fragile X, tremor, ataxia. So here's where family history of sort of different presentations but all sorts of come together here, that we have a Fragile X premutation carrier, we have some affected, then we see a whole diverse set of phenotypic presentations based on how this genetic condition is moving through this family from generation to generation. For full mutation carriers, for women, as I mentioned, they're not really fertility issues, but they may have Fragile X physical features, and they may have normal cognitive functioning or slightly impaired, and they may be more affected by depression and anxiety. I think that's important to remember. And then men have the classic Fragile X condition. So next step. In this case, we would offer Fragile X testing to Anna and Harold. So were she not pregnant, we would start with the brother and ask that the brother be tested, and then offer Anna testing. However, since she's already pregnant, we would consider, in the interest of time and providing additional information to this family, testing Anna and her brother concurrently. We suggest that the family undertook genetic counseling to understand this situation for the whole family, and perhaps bring in Sarah, the mother of Anna and Harold, because that would help to spread the information throughout all the siblings. Anna's anxiety level is somewhat high based on this, so we want to really have her have the opportunity for both genetic counseling and then perhaps psychosocial counseling if she felt that would be useful and helpful to her. When we go ahead and do the test, in this case scenario, Harold tests positive for Fragile X. Anna, turns out, is a full mutation Fragile X carrier, and then it turns out that Anna is carrying a girl. So that's, in general, reassuring that the daughter would probably have a 50-50 chance of having what she has, but she doesn't have the chance of passing the mutation on to a boy. So what are the future implications? Anna, as a full mutation carrier, will not have infertility issues per se. She may have some cognitive functioning decline. She is more likely to be affected by anxiety and depression, and so certainly in delivering a genetic diagnosis to someone for whom anxiety and depression is an issue, this must be considered and can certainly help and support her through this. For her daughter, she'll have a chance to have early and regular developmental assessments, because we'll already know that she's at risk. And then for future pregnancies, 50% chance for being a full mutational Fragile X carrier. So that's what any daughter would have. They might get the affected X or the unaffected X. And then for boys, 50% chance for being affected again, because the Y would come from their father, and then they could get either the affected or the unaffected X from mom. So 50% chance for Anna to pass this to subsequent pregnancies. And so reproductive options would want to be discussed here in a way that would allow Anna and her partner to make choices. Now for the sister, what happens there is challenging. We don't generally call siblings and say, guess what, here's test results that impact you. But we do want, of course, families to share information. So we would talk with Anna about discussing with her sister what she has and what she carries, and then what that means for Marguerite, and encourage her to have Marguerite come in to see us to discuss what the test means for her. So sharing genetic information within families is a huge challenge, and usually building rapport and having families build rapport with providers such that additional family members can come in as needed tends to be the most successful approach. Any questions on this that anybody wants to call in or type in?
Yes, we did have a couple of questions on that case study, Siobhan. The first is about fetal alcohol syndrome. What is the relationship between fetal alcohol syndrome and alcoholism? And then a follow-up, at what age is fetal alcohol syndrome detected?
Okay, so alcoholism would be, It's a good question, and I'm actually not expert enough to give the answer, but it has to do with dependence on alcohol, quantity of alcohol, and then interfering with functioning. So that's for the individual to think about whether they have alcoholism per se. For the fetus, however, there's no safe threshold of alcohol. So let's say you're like a highly functioning mom, but you drink, 4 glasses of wine every night. No matter what you call the mom, alcoholic or not, and I'm not even wanting to be judgmental or anything, 4 glasses of alcohol a day is too much for a developing fetus, and the fetus would be at risk. So we know alcohol is a potent neurotoxin. It's just not good for developing neurologic system, no matter, all judgment aside. So basically, for the newborn, the idea would be for the mom to screen and say, we've got to get you off this alcohol during pregnancy for your developing fetus. Throughout the pregnancy, there's no time window that's safe. There's no amount that's safe. And then for the fetus, once the child was born, again, developmental assessment, and it would, there's some facial features like a flattened lip and so forth that can be seen in a child with fetal alcohol syndrome. Mostly has to do with quantity and duration of alcohol exposure in utero. And then the assessment is developmental assessment. Is the child meeting milestones? And if not, then start to offer interventions. Regardless of the etiology, early intervention, physical therapy, occupational therapy, are interventions for young children that are effective and useful, whether we know the etiology of the intellectual disability or not. Does that make sense?
I think so. Thanks, Siobhan. We had a couple more questions on that case study. Is there a typical pattern of progression from pre-mutation to full mutation through generations, I guess, for Fragile X?
Yes, excuse me for not answering that. So for pre-mutation carriers, it's the length of their pre-mutation, so it's somewhere between like 50 to 200, and there's a table you can look up on gene clinics, gene reviews, and it tells you for the size of the pre-mutation, the likelihood for it to expand in the next generation. So that has to do with the length of the number of triplet repeats, and so it varies by the length. And like I said, gene clinics, gene reviews, if you look in there under the Fragile X, the table's in there. And frankly, I'm sorry I don't have it in my head, but when I have counseling on that, I just pull that table out so I can give the statistic of the percentage likelihood that the pre-mutation will expand to a full mutation in the next generation. Remember then, if the next generation is a boy, the boy will be affected if they get a full mutation. If the child or the fetus is a girl, again, they will have an effect, but not as dramatic as the male.
Great. And we had one more question that was more general. That you know of, are there any apps for smartphones that assist in clinical decision support or in taking the family history?
There's not, and I was at meetings this week saying we need to make a family history screening tool for iPhone apps. So whoever asked that question, I'm right there with you. I'm absolutely positively thinking the same way you are. And if anybody has any ideas how to put that together, let me know, because I honestly, truly have been thinking more and more that genetic red flags would make a great iPhone app, and I'd love to do it. So, get in touch, please. All right, should we go on to the next case study, Vaughn?
Yeah, let's do that, and then we can take more questions after.
Okay, perfect. So case study 2 is about a family with another condition. Soledad and her husband Robert, an American soldier, present to your office for a preconceptional care visit. Soledad and Robert are both 28 years old. Soledad grew up in Mexico, and she and Robert moved to the community about 6 months ago due to Robert's assignment to the local military base. Soledad's primary language is Spanish, and she requires translation, which is provided by Robert during the visit. The couple's thinking about trying to conceive again. However, they are apprehensive since 3 years ago they lost their first baby due to complications associated with an opening in her spine. So the question is, what's going on here, and how can we help this family, because they've obviously had a very devastating experience losing a child, and that makes it hard to think about becoming pregnant again. So what are we thinking about here with Soledad? Probably some form of spina bifida, a neural tube defect. Neural tube is what forms around 28 days after conception. So right around when you're missing your period and realizing you're pregnant, your neural tube should be closing, and it kind of closes like a zipper. It just, goes linearly as it comes around and makes a column and closes. And sometimes it fails to close, and about 1,500 to 2,000 babies are affected each year with this condition. It can be more to less severe based on how extensive it is and where it is on the spinal column. And treatment can include surgery, physical therapy, and assistive equipment. It's a complex condition, which means it has genetic and environmental influences. And so the thing about neural tube defects is that we have some really effective mechanisms to prevent it, which are mostly around folic acid fortification. So risk factors for having a neural tube defect are insufficient maternal folic acid intake and metabolism. And we're learning more and more about the genetics of that metabolism and what genetic variants might put women at risk. But for the moment, we know that not having enough folic acid on board can be a risk factor, or I should say is a risk factor. Other risk factors include uncontrolled maternal diabetes, so very high glucose levels in the blood around the time of the closure of the neural tube, maternal obesity, excess maternal alcohol use, high maternal core body temperature, Accutane use, and Accutane is a drug that is like retinoic acid and is often used for the prevention of acne, and it's a vitamin A analog. And then chromosomal disorders, trisomy 13 and 18. So these are all risk factors for neural tube defects. And we also know that there's probably some genetic predisposition because we see recurrence risks, 4% risk if there was a previous pregnancy with neural tube defect or if one of the parents had a neural tube defect, and then 10% risk if a patient had 2 previous neural tube defects, children or pregnancies with neural tube defects. And we also know that higher risk populations are Hispanics and Caucasians. So putting this all together, when we think of Soledad and Robert's situation, we see that they have a previously affected child. They're of the Hispanic ethnicity. Soledad is, in fact, so her ethnic predisposition would be such that she's at increased risk. And so what can we do to help her? How can we turn this information into empowering information for her? Well, first of all, an individual who's had a previously affected pregnancy would be encouraged to take a higher dose of folic acid, 4 milligrams. So the normal standard is 400 micrograms, which is less than a milligram. It's 0.4 milligrams. And this is being asked to take 4 milligrams. So it is 10 times what we would give every woman. And that's really important. When someone's been previously affected, because there's probably some genetic predisposition and because we know that they are someone who needs a lot of folic acid, we up the dose 10 times. So this is for high-risk women, but very important because it makes a big difference in prevention of second pregnancies being affected. We'd also recommend nutrition counseling, genetic counseling, getting records for the previous fetus to see what really went on, make sure we have the full story, and see if there's anything else we can contribute. Another thing you'd think about is, did Soledad possibly have diabetes and not know she had diabetes? And so maybe the situation, and this happens for a lot of women, where they never really get to a doctor until they're pregnant, and so they don't have a condition like diabetes diagnosed prior to pregnancy, and so getting their sugars under control is not affected until they're already pregnant. So moving that into the pre-pregnancy state would be great. And then the other issues were to really try to reach out to Soledad and try to get some bilingual staff involved in working with her so that she can interact with your practice and learn from the counseling staff in Spanish as well as in English. Now, what about implications? Well, risk for future pregnancy, we just talked briefly. So having had a previously affected pregnancy, we want to give her about a 4% risk of having a second child with a neural tube defect, but we want to follow that up very quickly with how important preventive measures are and how she can bring that 4% risk down with folic acid supplementation. Prevention steps, as I said, folate-enriched diet, and she'd get some nutrition. We'd want her to get some nutrition counseling to understand what foods to focus on, and then the 4 milligram periconceptional folic acid supplement. It's too late to wait till you've missed your period, you're pregnant, and you're going in to see your doctor. We want this folic acid on board at the time of conception, so we suggest women take prenatal vitamin with folic acid, or in the case of Soledad, her increased supplementation starting the minute it even crosses her mind that she may desire to become pregnant again. And then we'd also want to offer her screening and diagnosis for neural tube defect. Maternal serum alpha-fetoprotein would be the screen for neural tube defect, and ultrasound would also be screening and possibly diagnostic. And if need be, an amniocentesis can be performed to test the amniotic fluid for markers that are diagnostic of a neural tube defect. And so the anatomy ultrasound would be very important. All right, any questions on neural tube defect? Good news is that in the United States, wheat has been fortified and cereals have been fortified, so we're having a public health strategy to get more folic acid into the food supply, and we've seen rates of neural tube defect go down nationally, so that is a wonderful and amazing success. But we still can do more to promote women knowing about and following the recommendation for folic acid supplementation. 0.4 milligrams for all women, and then 4 milligrams for women with a previously affected pregnancy. Questions?
Nothing has come in so far on neural tube defects.
Oh, great. We'll go on to case study 3. Sorry?
Yeah. Go ahead, and I think we can ask these. We have 2 questions, but they're more general, so at the end.
Okay, perfect. So Keisha is a 34-year-old African-American woman. She presents to your office for prenatal care. She's accompanied by her husband, Sean, who's also 34 years old and also African-American. Keisha's 10 weeks pregnant. This pregnancy was unplanned. This is the couple's first child. However, Keisha has a son, Eric, who's 5 years old from a previous marriage. Keisha tells you the story of receiving a call from Eric's doctor, her son's doctor, that his heel screened positive for sickle cell disease. Follow-up testing confirmed that Eric did, in fact, have sickle cell disease. Keisha recounts her shock and dismay surrounding Eric's diagnosis, as she thought the disease had been cured. The family has endured many social, emotional, and financial hardships since Eric's diagnosis. Keisha also describes feeling helpless during Eric's frequent pain crises. So sickle cell anemia is a really serious condition, and this scenario where a family may not know they're at risk, but one way they become aware is that their child has a newborn screening test that reveals an abnormal hemoglobin, and they go ahead and get a diagnosis of sickle cell disease is extremely common. Now, sickle cell disease is due to a point mutation in the beta globin gene. It causes red blood cells to take on a sickle shape when there's low oxygen in a cell. There's about 70,000 to 100,000 individuals in the United States with sickle cell disease, and it is a challenging clinical condition. It can cause some severe symptoms and need for hospitalization. When cells sickle, they can sort of clog blood vessels, and they lead to painful crises where the tissue's not getting oxygen. The anemia a patient can experience anemia due to the shortened lifespan of the red blood cells, and so children and young adults and adults can have a number of pain crises and need for hospitalization for both medications, and also need for hydration, and also susceptibility to infection. So a well-known disease, but sadly a very difficult and complicated disease to manage. Today, in terms of treatment, there's limited success with with blood and marrow stem cell transplants. So treatment is really around relieving symptoms and complications, which includes managing pain, big part of lifestyle management, blood transfusions as needed, prophylactic antibiotics, so during childhood especially to prevent infection. Another piece of that is rigid adherence to vaccination guidelines, so that vaccinations are up to date and children don't get many of these childhood infectious illnesses. children need routine eye checkup by an ophthalmologist and then head ultrasounds to detect stroke risk, especially if some of the sickling occurs in their brain. The inheritance pattern of sickle cell disease is autosomal recessive. Sickle cell disease, as well as abnormal hemoglobins in general, are included on all state newborn screening panels, so in all 50 states. Sickle cell trait may be detected on a newborn screen, and so distinguishing between trait and actually having the disease, so being a carrier, which is to carry one changed copy of the beta globin gene, versus having sickle cell anemia, which is to carry two changed copies of the beta globin gene. Newborn screening does not always distinguish those two possibilities. So the phone call from the newborn screening program or the pediatrician is a screening phone call, and what it requires next is a diagnostic test of the child themselves to see, do they have trait or carrier status, or are they affected? Now, of course, once a child is affected, there are implications because that implies that both parents are carriers themselves. So again, genetic information is shared within a family, and so when a diagnosis is made, there are implications for other family members as well. Carriers are healthy and unaffected, so while there's been some controversy and some stigma around being a carrier, there's very little evidence that that is associated with poor health. There's some controversy around screening. NCAA has put out some guidelines about screening intense college athletes for sickle cell carrier status, so that's an interesting and open debate and ongoing issue. But in general, carriers are healthy. More than 2 million Americans have sickle cell trait, and so again, it's very common to be a carrier. About 1 in 12 African Americans and 1 in 100 Hispanic Americans. So what do we see in Keisha's family history that makes us think about genetic condition? Well, first of all, family history of sickle cell disease, and in this case, probably Keisha realized she was a carrier of sickle cell trait when her son Eric was born and diagnosed with sickle cell disease. Because Keisha and her partner are both African American, they are in an ethnic group that has a higher carrier rate. So what's the next step? Well, first of all, remember, we already know Keisha's a carrier, so first step is to test Dad and see. And the screening test, or the first step for testing Dad, would be a CBC, a complete blood count. You'd look at not just the hemoglobin, but the MCV, the mean corpuscular volume, and try to see if there's either an abnormal hemoglobin that fits the pattern of sickle cell anemia or another abnormal hemoglobin like alpha thalassemia or beta thalassemia. And again, for those of you who are primary care folks, we wouldn't be expecting you to get into all this level of detail as much as to sort of identify something going on here and then potentially send the family on to a geneticist or genetic counselor. So what are some of the other considerations here, though? And these are real insurance considerations. A lot of partners don't have insurance. So if they don't have insurance, or they have concerns that their insurance or their job might be in jeopardy because they don't want to find out they have a genetic condition which would jeopardize that, these are serious and real considerations. So getting Dad tested is an important next step, but does sometimes raise these issues. And then cultural considerations. Some families may be more likely to or be resistant or hesitant to discover, identify information, and maybe some families would be concerned about racial discrimination or being put into some category which they felt like could have negative consequences for them. So what ends up happening is that Keisha and Sean discuss this, and they decide that Sean will go ahead and have and be tested. And so he does test actually positive for sickle cell trait. So he too is a carrier. So now we have two carriers with a carrier couple, and they are pregnant. So what are their chances? Well, this is an autosomal recessive inheritance pattern. So 25% chance that the baby will get the unchanged gene, or the quote normal gene, from each parent and be unaffected. A 50% chance that the child will receive one of the changed genes and will be a sickle cell trait or carrier like each of their parents, And then there's a 25% chance that the child will get the changed beta globin gene from each parent and will be affected with sickle cell disease. So these are the kind of statistics we'd really want to give this family and have them understand that these are the risks to their pregnancy. Then, well, given that Keisha's already pregnant, we want to go ahead and offer her prenatal testing, and that could be or prenatal diagnostic options. Those would include doing nothing and just saying, okay, we understand our risks, and we're going to go ahead and have this child, and we'll have the child tested at birth. We know the child will be tested at birth due to newborn screening. And then for prenatal diagnosis, there are two options: chorionic villus sampling, which is done between 10 and 12 to 13 weeks, and is basically essentially a biopsy of the placenta to test those cells for hemoglobinopathy, and then amniocentesis, which is done after about 15 weeks. And in all of these instances, we would suggest having the family see genetic counselors so they could run through and understand and explore their options and what information they want at which times and what kind of decision making that would allow them. And so they go ahead and have an amniocentesis, and the baby falls into that 50% category of having sickle cell trait, being just like each of his or her parents. So future implications for this couple, one is newborn screening. So again, this child known to be a carrier, they could certainly get a call telling them that the newborn screen was positive, because the screen may pick up carrier status as well. The child would want to, at some point in their life, understand that they're a sickle cell carrier and what that means. It doesn't really mean much to them until they become in the role of thinking about becoming a parent themselves. And then future pregnancies. So again, the pregnancy risks are going to be the same for each pregnancy: 25% chance of nothing, 25% chance of being affected, and then 50% chance of being a carrier. We'd also point out to this couple that if they were to have a pregnancy with a different partner, the risks would change based on the new partner status. So in conclusion, I wanted to just run through I hope what was illustrated here are some nice opportunities to use family health history to understand an individual's risk and use it in the prenatal period. Things we've heard about and challenges we all are trying to work on: overcoming the time issue. Do we have time to sit and collect this information? We're developing tools to have individuals and patients put in some of this information, do it at point of care, do it at home, bring it into your provider, and then also working in teams where we have counselors and other folks working together in the clinical team to try to and put it to good use. Building skills in collecting and analyzing family history is important. It's not easy to draw a pedigree the first time or the second time or even the third time. Figuring out how to lay it out and so forth can be challenging and gets better with practice. It also is facilitated by a lot of electronic tools which do really beautiful pedigree building for you. Another challenge is to keep family history available and current. So it's not a static issue. Your family history today that you give your doctor or your provider is wonderful for today, but in a year, in 2 years, in 3 years, it's going to look different. Families evolve, families grow, family members become ill, things happen. So it needs to be updated each year, and usually you can add to the pictorial representation the new information. We continue to work as a huge collaborative team on getting risk assessment and care plans to be most up-to-date, most current, reflecting information that's really rapidly being discovered. So by doing that in electronic fashion, we can make sure that clinicians everywhere have the most up-to-date information. We want to keep having these family history tools serve as a way for primary care and genetic professionals and communities to work together. So we would love for family docs and OBGYNs and folks on the front line to say, is this genetic? And then figure out, I've got a bunch of red flags here, let's send this person over to genetics, so that we are all working together as teams between the front lines and then the specialty care that may be needed at times. And then another challenge can be reimbursement for family history, although it is part of a lot of comprehensive panels, so we hope it's gaining its support and it's showing its value to be reimbursed for. And so at this time, I'd like to close the formal presentation. I'm just about one, but I am available for any questions, so if anybody would like to ask them, please do.
Okay, thank you, Siobhan. We have several questions, so yeah, 1 o'clock, but thank you for your time to continue answering them. So first, what suggestions do you have for presenting a woman's risk to her in a way that she can visualize and understand? For example, quad screen revealing a risk of 1 in 325 for trisomy 21. What is the vocabulary to use? Probable, likely, unlikely, etc.
Yeah, I think all of that vocabulary isn't great because it's all kind of value-laden and, we're kind of imparting messages there. So what we try to do, and I mean, just from the reading, and I'm sure others on the call may have a better answer than I, but I'll just throw out my answer, which is to try to come up with objective representation. So say something like, if 300 women get this test result, one of them is going to have an affected child and 299 will not. So that it starts to go away from an abstract number, fraction. Fractions are hard to work with, and it gets into a practical, like 300 women get this result, one has an affected baby, 299 don't. That kind of concrete explanation we find can be particularly helpful to women as opposed to 1 in 300. Is that a high risk or a low risk? I'm not really sure. So that's one of those strategies we can use.
Great, thank you. Back to the neural tube defect. If a woman has a history of a fetus with neural tube defect, would you suggest the higher 4 milligram folic acid dose for a pregnant sister of the woman?
Oh, great question. The data's not there, nor are there any recommendations. However, it's not that it's been looked at and shown not to be useful, and so it's one of those things where, your gut might tell you it's not a bad idea to do, even though I couldn't produce evidence. So when you're weighing the risk and the benefit, folic acid is a water-soluble vitamin. There aren't thought to be dramatic downsides to a higher dose. So one could, in consultation with a provider, decide to go on the higher dose, with the idea that even though there's not significant evidence to support it, there's not a strong downside. But, it's a really good and interesting question, and I would suggest talking to the provider, and I could see them certainly going that way of erring on the side of taking the higher dose intervention. In Europe, the higher dose is offered for many, many women, so there are populations where the higher dose is out there.
Great. A couple more questions related to the case studies. Is there any intolerance for folic acid in pregnant women?
Yeah, not really. There are some concerns and controversies about cancer risk with high doses of folic acid, and then masking, what's it called? The pernicious anemia, but that's usually in older adults, so it's not usually the same profile. So there's a little controversy about folic acid, but not a lot. And as I said, there's some populations where higher dose is recommended for more people. So general for pregnant women, the benefits outweigh the risks. But again, if someone has concerns, certainly, even if you don't have concerns, talk to your provider to make sure that in your individual case, you're on the right dose for yourself to maximize your outcome.
Okay, thanks. We had a comment come in regarding the risk communication question. It says, when I discuss results with patients, for example, quad screen results, I find it helpful to convert the fraction to a percentage. For example, a risk for trisomy 21 of 1 in 325 is the same as a risk for trisomy 21 of 0.31%.
Okay. No, that's great. And another thing, I've read papers saying, this is the right way to do it. That's the right way to do that. What I end up feeling is different people might understand it differently, so you could try a few different ways and see what resonates with the person, because people do think and understand differently. So that's another sort of general concept I have. Some people like fractions, some people like percentages, some people like numbers, so to have a couple of possibilities and see what is most useful to the client that you're working with.
Thanks. And then we had a question on when you were talking about sickle cell, that are there side effects, particularly in young people, in using the treatments for this problem that you presented?
When you say treatments, meaning treatments for sickle cell anemia?
Yes, the question came up during that case study.
Okay, so antibiotics preventive antibiotics don't have huge side effects. There are some, giving blood transfusions can have an iron overload as a side effect because, your body has a lot of extra iron. The pain management can be challenging. Sometimes children or young adults get involved in too much pain medication and, finding they're seeking pain medication. Sometimes young adults are not treated enough for their pain and end up living in a lot of pain. So, sadly, it's a difficult condition to manage, and there are a lot of side effects to treating and side effects to not treating. And there are also some other treatments, and I apologize, I'm not a hematologist or a particularly expert in caring for children with sickle cell disease, so I wouldn't have the latest treatment options right at my fingertips, and I apologize about that, but there may be something you're alluding to that does have some downsides, and I'm sorry, I'm just not as aware of that.
Thank you for your comments. Siobhan, I think you had mentioned that people could contact you if they have additional questions. Is that possible? Because we had a couple more that I think were related to different types of testing that at this point, since we're about 10 minutes over, might be better covered offline. So.
Yeah, sure. Is my email on the webinar page, Yvonne?
It is.
Okay.
It says, yeah.
Because people could certainly email me, and my email is my name with an M in the middle because my middle name's Mary, so Siobhan M. Dolan @yahoo.com.
Great. So thank you very much, Siobhan. Thank you to all of the participants who were with us today and for asking questions. The session was recorded, so it will be available for streaming and downloading next week, and please do fill out that survey as you exit the webinar software. And I think I speak for Siobhan as well. We invite anyone who's interested in this to contact Siobhan, contact Genetic Alliance, if you think you might be interested in working with us on the prenatal tool family history screening questionnaire that Siobhan mentioned in the beginning.
That sounds great. Thank you, Vaughn, and thank you to Genetic Alliance and to the wonderful audience, and I appreciated your questions and speaking with you today. Thank you.